Thank you, Venki, for inviting me and giving me the topic that is the other end of the spectrum. We always treat the lower extremity venous disease. Now we are talking about the upper extremity and SVC syndromes. So I have no disclosure for this topic. Etiology, it should be divided into three categories. It's within the thoracic cavity, at the outlet of the thoracic cavity, and the extremities. So if we look at the SVC syndrome, it's usually the malignancy would be number one cause of SVC syndrome. The next ones are catheter-related, pacemaker wires, radiation are some of the other causes. And upper extremity, again, we know that it's going to be end-stage renal disease, usually is the most common cause that we deal with, and PICC lines. Paget-Schroeder syndrome is in between the thoracic cavity and the outlet in the extremity. Now, as far as the classification is concerned, it's pretty standard Stanford classification where both the subclavian occlusion would be easier to manage because the collateral there would be a zygous vein. If you have type 1, it's bilateral subclavian or innominate on one side. And then it's above the zygous vein would be type 2. And if it's right at the zygous vein, it would be type 3. And below that would be type 4 involving the SVC. It's important to know this classification because with the collaterals, you might be able to get away with some of those obstruction and not having any symptoms. So your treatment will change based on that. These are some of the depiction of the collaterals that develops depending on the level of obstruction and the tightness of the obstruction. Now, there's a clinical scoring system, which is the Kishi scoring system. You'll have to define which ones you are going to treat based on their neurologic symptoms, which involves stupor, coma, blackout, blurry visions, headache, and each one is given a point. So if you can put all those things related to that and laryngopharyngeal symptoms that involves orthopnea, laryngeal edema, stridor, hoarseness, and some of the nasal and venous dilatation of the neck. So each one is given a score, and anything that's more than 3, if you look at the U classification here, we have a severe grade 3 classification, which would need some treatment for the SVC syndrome or upper extremity related issues. There is also an operative risk. Because of the lack of time, I'm going to keep on moving. So there's not much data on SVC syndrome, and only study that I could come up with is a review article of about 700 patients involving 930 stents. And this is a good review article which can give you some indication as to what the treatment option should be. Stenting is one of the commonest things that can be done. So if you look at malignant and non-malignant lesions, there is a patency rate of 800 days. And the important thing to realize is in malignant cases, the complication or mortality is similar to the one that are non-malignant cases. But as far as the complication goes, it's more with non-malignant lesions. So using stents and other stuff, you want to be a little careful when it's a non-malignant lesion that you're treating, trying to take away the obstruction of SVC. Some of the case reports are there. And here are some of the examples. Just like we have the issue with the confluence at the iliac vein and the IVC, we deal with the similar issues at the upper part of the body. And here, again, there are case reports. There's not much literature to go by. And these are some of the reports where you have the stent struts dilated and putting a stent right across. Couple of examples, again, in malignancy, the symptomatic relief is good. This is what you don't want to do, actually. This is a case that I had it in one of my institution where the stent just slided down, and stenting across the heart I don't think is really advisable at this stage. But it does give you some results. Now, innominate vein, we treat, everybody knows how we treat those, and with all the new technologies, we can cross the CTO, just like we do with iliac veins. We can easily cross the CTOs, and then we stent across, and they have good results. Most of the people that we deal with as vascular surgeons are related to dialysis access and the catheters. Here it's an SVC just below the azygous vein, so you can see the stent that is deployed and dilated. Just to fulfill all the list of the things, there is a comprehensive review about Paget-Schroeder syndrome. There's a lot of stuff that has been done. A most common cause for Paget-Schroeder and clinical finding is related to the neurologic symptom. Venous is in between. And the first 14 days are the golden days where you can treat those patients in thrombolysis. And then there is a whole controversy about what you are going to do after you do the thrombolysis and how you are going to deal with the vein. And that is a controversy that has not been resolved. Each institution has their own protocol policies and how you treat with the rib resection or whatever you do with the scalenus muscle or whatever the obstruction you think is there. Stenting versus non-stenting, which is also a controversial topic. I'm going to leave it at that because it's very limited time. And then if you go to the next levels of obstruction beyond the thoracic outlet is going to the upper extremity, including the subclavian vein. Here you can see in-stent stenosis, which we deal commonly with dialysis patient. Again, it's on the left side, similar to the right side, but the stent is extended further out. And for upper extremity, dialysis access is the most common cause. And again, there you do the thrombectomy and angioplasty. And these are all the standard things that we do. One common thing that we see with the pacemaker leads is if you can cross the lesion, you can angioplasty and you would have a decent result. Stenting in that area is a little difficult because you will trap the wires. This is what I would not want to see or get done in the upper extremity. Trying to create parallel system with the branch graft, it doesn't stay open. So that's one thing that's not really recommended, but it has been done. This is, again, one of those examples of what you see clinically, and the pacemaker wires or AICD wires. And there's a stenosis which just needs to be dilated, and if needed, you can bring them back and dilate that. There's no need to stent that because it will become worse. These are, again, some of the examples. If you have pacemaker, portacat, sometimes there's a catheter that is left in for 4 or 5 years and it gets stuck. So a simple thing is to just put the wire and go from below and push everything as a system and pull it out. Okay, I made it in time.